Good morning to all of you. A warm welcome to our Zoom webinar organized by GMOA and Society for Health Research and Innovation. Today, our lecture is going to be on common problems in newborns. Kindly mute your microphone and turn off the camera during the presentation and use the chat box to clear your doubts at the end of this session. Now, it's my pleasure to introduce today's speaker, Dr. Sanjeeva Thenakon, consultant neonatologist, currently attached to the Colombo North Teaching Hospital. Thank you for joining us today, and the floor is yours.
Good morning, everyone. Thanks for being with us despite your busy schedules. I know everybody is busy during this COVID period, but just to upgrade your knowledge about neonates, I thought of continuing this lecture. So we'll talk about common neonatal problems that you all face day to day, and sometimes I might not be going through all the slides, content of the all slides because of the time factor. So as a medical officer directly involving in the patient care these days, you might be encountering certain neonatal problems, common problems. So just this is not a new thing, but we are just brushing up your knowledge and we are just polishing up your knowledge to give a good patient care, right? So newborns, newborns are the most precious gift on earth for a couple of parents. Uh, Therefore, I mean, they have big hope on the baby. They are a bit anxious. Therefore, sometimes the real problem is a bit exaggerated. You know that. So sometimes these problems are not real problems. They are just a worrying factor for mother, father, as well as the grandparents. But keep it in mind. Don't ignore it. Just get the problem into your lap and solve it. Otherwise, they will lose the grip and they will go to somebody else and they will end up in some quack or some irrational practitioner. Therefore, always listen to their problems positively and always encourage them and always be empathic on them and get their problems. Sometimes they are not may not be much on the problem, but just give a solution and just uh, allow them to talk and listen to them and give a solution, right? So pay your attention to the problem. During this period, during the puerperium, mother is very fragile. She is like a eggshell, very fragile. So because of the hormonal changes, because of the first time experience of a childbearing, she is very fragile and a lot of pressure on her father, mother, as well as the mother-in-law. So many family members are putting their ideas, putting their opinions on the baby, right? This is, I mean, a bit of a hazard just for the mother and bit of a stressful for mother. So when mother comes to you with a problem, with a concern about baby, so don't just ignore it. Just take it to your own lap, own hand, and try to settle it, right? So always try to encourage them and try to get the real problem out of them. So no mother will say that I have got enough breastfeeding. I'm satisfied with the breastfeeding, right? So everybody has problems with the breastfeeding. Say, "Ane doctor mata kiri madi ena wage." Kisi mama kenek kiyanne mata kiri ena athi kiyala. So that is a real concern of the baby. They are concerned that their volume is not enough. They are concerned that baby is not baby is going to be hungry, baby is going to be hypoglycemic. So just get the question onto your lap and explain them about the situation and give them the solutions. Otherwise, what will happen? They will go for quick solutions like formula, right? So formula is, there are a lot of side effects. It's a quick solution, and most of our, I'm not that happy to say, no, most of our colleagues, they don't have enough time to spend on one patient, especially regarding breastfeeding. So they prescribe formula, which is not good at all. All of you know that formula contains a lot of palm oil and unnecessary chemicals. So as a GMO, we have been telling this for last 10 to 15 years. This palm oil is a really toxic product, and is has really detrimental effect on the newborn. And at last, it might end up in so many other complications. Therefore, don't promote formula in case of breastfeeding failure. Which the breastfeeding failure is the commonest problem that you encounter in your practice. So we'll talk about breastfeeding, but in case of breastfeeding, I know that you need time to attend, time to engage, time to listen to mother's story, time to give solutions. It's not a 1 minute or 5 minute or 10 minute session. It takes about 1 or 2 days or 3 days or 4 days or 5 days, sometimes week or 1 or 2 weeks to get rid of the problem. But be patient and go with the patient, and you may have to get down the mother and the mother's parents and mother-in-law several times to settle this problem, right? But it's really worth, because just by giving a substitute for breastfeeding, just by giving what you call formula for this problem, you will end up in mess. So very formula is very attractive. Why? It will keep the baby fat, right? It will keep the baby very flushy and very fluffy, which will make the mother happy, right? But it's not healthy. You know, the babies might end up in a lot of allergies, a lot of infections, and a lot of non-communicable disease later stage. Therefore, breast milk, you have to encourage it, and with the time you have to settle it. So you have to take the mother's opinion and listen to the mother very carefully, and then you have to tell your version, saying that amma මේ පොඩි කාලේ ඔය ඔච්චරම කියන තරම් breast milk volume එකක් ලොකුවට ඕනේ නැහැ. බබාගේ බඩ පොඩි ස්ට්‍රෝබෙරි ගෙඩියක් වගේ. පොඩි volume එකක් තමයි ඕනේ. right? ඔය ටීවී එකේ පෙන්නන වගේ ලොකුවට බබා පැය ගාණක් බොන්න අවශ්‍ය නැහැ. පොඩ්ඩක් බීපු ගමන් බඩ පිරෙනවා ඒගොල්ලන්ට. හරි. ඒ වගේම එයා හරියට දවසට 5 පාරක් විතර චූ දානවා නම් දවසට 2 පාරක් 3 පාරක් බවල් ඕපන් වෙනවා නම් ඒකෙන් කියන්නේ ඇති කියලා. හරි. Mothers think that mothers has to express 100-120 ml per one go. No, it's not like that, right? So tell the mother. And certain other social factors are also influencing the mother. Mother-in-law, mother's mother, so many other helpers might come and give various opinions about breastfeeding. So therefore, try to get the mother under your control. The way to do that is listen to mother, patience. Don't jump on her. Whatever she says, whatever she is trying to say, get it positively and encourage. And sometimes I know that because of your busy schedule, you are not, you are not in a position to handle her. But you know, every base hospital and above has a lactation management center, right? So refer the mother to lactation management center, right? There you have very well trained nurses, right? Very well trained nurses, very well trained midwives, very well trained doctors. In the case of doctors, it's always better to be handled by a female doctors, because mother can truly come with her concerns. So always give a merit to mother, saying that amma ada hondai, ada ඊට වඩා ගොඩක් improve වෙලා තියෙනවා breastfeeding. Always give positive feedback on mother and keep on going. It might take 1 or 2 weeks to settle, but it's real worth rather than starting formula, right? So keep on keep on getting the child for 1 or 2 or 3 or 4 occasions. It's always better to refer the mother to breastfeeding center, lactation management center, and keep a slow going process to improve breastfeeding. And sometimes mothers need psychological support as well. Just by saying amma breast milk is the best, is better than formula, you have to give breast milk, will not going to help. Most of the mothers are depressed because when they go home, mother-in-law will say, "Ane kirimati." That's a very hurting word for the mother, very hurting word for a female. It's like saying you are ugly, right? So always go for psychological support. In my case, I always refer to female psychiatrist. So she will always encourage her mood. That will really help, right? So always better to handle by a female doctor. So mother can really come with the own problems. And not only breastfeeding. So there are accompanying problem as well. One thing, so her sleep, right? Her sleep has to be improved because, you know, let down reflex improves in sleep. Let down reflex, improves in during sleeping. Oxytocin fatigue that will improve while you're sleeping. Therefore, allow mother to sleep when the baby is sleeping. Don't occupy the mother for other household work like washing clothes, looking after the other child. So always when the baby is sleeping, allow mothers to sleep. So that will improve the let down reflex. That will make more milk. And be very cautious about mother's food intake. During this time, mothers, they are in a bit of a depressed state. Therefore, they don't eat much, but that's not going to help breastfeeding. So always encourage them to take, this traditional, they call it jackfruit and tender jack. Those are really helpful, right? So at least help them to get 3 main meals per day and some additional meals like triposha, like so many other nutritious stuff uh, during the lactation period. So don't allow them to take coffee and caffeine. So coffee and caffeine containing foods, they will disturb the sleep. So disturbing the sleep will have a negative effect on breastfeeding, right? And do not allow to take substances which cause constipation. Constipation has a negative impact on breastfeeding. So allow mother to take a lot of fruit, lot of fiber containing diet, and discourage them taking chocolate and a lot of short teas and coffee, right? And the other thing is always help the mother in positioning the baby. Sometimes because of the cesarean wound, because of the spinal scar, they are not in a position to handle the baby, right? So proper positioning will help the mother's breastfeed. So breastfeed is the most appropriate and natural food for the baby. So it will protect the baby against infection like diarrhea. If the mother is 28 years old, all the infections that she had been encountered by antibodies, which are deposited in the bone marrow and which will be transmitted to the baby via the breastfeed. So it protects the baby against diarrhea, bronchitis, pneumonia, immunological, and even for immunological disorders, it will give us protection for the baby, right? Then, so you have a lot of positive effects on breastfeeding. Favors uterine contraction and reduces PPH, reduces the uterine ovarian breast cancer, lactation amenorrhea, helps in family planning, and it saves money and decreases the need for medical consultancies and drugs. And especially when you are preparing formula milk, it takes a lot of time, right? You boil the thing, you have to do so many other things to get a proper formula feeding. Therefore, it consumes a lot of money and time, right? And how am I going to start? As soon as the baby is born, you have to start breastfeeding. There's nothing called within 1 hour, or early as possible. Why is that? Because when the time of child delivery, they don't feel that much of pain, right? But after 2 hours, they get severe pain, which will inhibit the let down reflex, which will have a negative effect on the breastfeeding. So as soon as if you start feeding, so breastfeeding will be started, there will be free flow, right? So there will be enough let down reflex. But if you are to start it bit late, the mothers will have a lot of pain on the spine, pain of the scars, that will have a negative effect on breastfeeding, right? So start it soon as possible, right? Then, so breastfeeding must be on demand. It should be demand feeds, not 2 hourly, not 3 hourly, but should be a demand feeds. So when the baby needs it, you have to know baby needs it, right? Then you have to look for the breastfeeding, right? There's no timetable for breastfeeding, right? It's totally depend on baby's demand. So you have to know the hunger cues. So early, mid, and late. So I'm not going to describe them one by one because it's a 1 hour lecture. It might take some time to describe. You can get it copied and read it, right? So always attachment is a problem. If you give a good attachment, nipple as well as areola, almost all areola is in the mouth. So it fixes very well and baby can suck very well. But if the in case of bad attachment, only the nipple is inside, right? So that allows a lot of air going freely into the baby's GI system, which will distend the baby and which can give colics and it's a vicious cycle and baby will not feed from the mother, right? And changing the questions help in prevention of mastitis and it will improve the flow. So therefore, always not a single position. You must try various positions at various times, even during sleep, while you are sitting, while you are standing. You can try various positions, which will actually help in uh, improve the let down reflex, and in turn, it will make more and more milk. Right. Right. So difficulties during breastfeeding, I told you always should be handled by it is good to be handled by a female person because mother can come with a real problem. So LMCs, there lactation management centers are there. All base hospitals and above they have lactation management centers. So mother has to be examined thoroughly and inverted nipple, flat nipples. Actually, these problems has to be dealt at the level of antenatal period. It's better to dealt at the antenatal period so then the problems can be encountered from antenatal period, and when the child is born the problems are almost solved. Then cracked nipples can be a sign of poor attachment. So that if you're getting a cracked nipple, that means baby's is not positioned very well, right? So you position the baby very well, and you can apply colostrum on the cracked nipple, so that will heal the cracked nipple soon as possible. Or some you can apply vitamin E cream or vitamin E capsule. Crushed capsule can be applied, which will heal it, and you have to position the baby very well, placing the nipple and the almost all part of the areola into mouth. Then it uh, will be healed automatically, right? So then breast engorgement, breast become hard, swollen, sensitive, and tight and dry and red skin with very painful breast. So solution is once again you have to express the breast milk and get it to a cup and start cup feeding from what you have extracted. And if the breast is engorged, always do a cold cold compression, not warm compression. If you give warm compression, it will be aggravated. So give cold compressions and reduce the pain and painkillers. Sometimes, if the area is very red and swollen, you can start antibiotics and keep on expressing. That will settle the problem, right? So then we'll go back to our other problems. So other, because I was very, very worried about the way our people were handling the breastfeeding issues. So many formulas has been prescribed. I have seen that. That's why I wanted to tell you this problem first. The problem of breastfeeding, though even though we think it's not that a serious problem, I think out of all these problems, is the most serious mistake done by us. That is prescribing formula. Formula is, I mean, it's a medical prescription. Sometimes in premature babies, sometimes in multiple pregnancies, formula might be helpful, but you have to think twice whether actually formula is really needed or not, because by giving formula sometimes you may be doing harm than good. In long term you are definitely doing a harm than good. Therefore just think twice and be patient, and always refer to patient to LMC lactation management center and try to establish breastfeeding as much as possible. So this is a transition period from intrauterine to extrauterine life. So therefore, it's a complex process involving virtually every organ system in the body. The most dramatic changes are seen in lung and the cardiac system. Failure to adequately make the transition can be life-threatening, and these infants often require supportive care. In order to select the optimal intervention, it is essential to understand the normal physiology of the respiration and cardiovascular transition, right? Right. So you have to know the general appearance of the newborn. Full term, they are very dark purple, red in color. Their movements are very symmetrical. They're vigorously crying with Mansi. keep the phone with you. Vigorous crying with accompanying activity of the arms and legs, lying with extreme motionless to conserve the energy for uh, breathing, right? So they are in flex extremities, sign of good muscle tone. That means sign of good muscle tone, and hands are tightly fisted with thumb covered by the fingers. Okay, but some you can see a baby who is crying and baby is very pink. All extremities are, at not moving, but he is crying. But in a case of breech presentation, you can see the babies in a sometimes some position called frog posture. Is in the lower down, right? So that is how the newborns look like. So you have to know about bit of a normal vital signs. Respiration rate varies from 30 to 60 per minute. Average is 40, right? So heart rate 100 to 60, 100 while sleeping, 160 while crying, right? Temperature rectal is a bit higher than normal, 37.5. Actually is somewhere around 37. So blood pressure average is 75 to 42, systolic is 6 to 80, diastolic varies from 40 to 50. Those are the normal variations, right? So as I told you from beginning, many problems are transient. They are benign, right? You need to just to explain the parents about the problem, right? But some needs your attention. Some need your intervention. So to differentiate these things, you need to get good detailed history, thorough evaluation and complete physical examination is needed to differentiate between the problems that you need intervention and the problem that you don't need intervention, right? So benign condition that you are facing, vernix caseosa, that is whitish cheesy-like covering on the newborn skin produced by epithelial cell breakdown. This will facilitate the vaginal canal, delivery of the baby. So that contains a lot of lubricant-like thing which will facilitate the normal delivery, right? That prevents transepidermal water loss. So that will prevent hypothermia as well. So now they have found certain kind of immunoglobulin now also. They are therefore don't pipe it vigorously and remove it. Let them go off automatically, right? Will fall off in 1 to 2 weeks time. Removing the vernix for cosmetic reasons is not recommended because it gives some protection to the skin from outside organisms, right? And it is a sort of protection for hypothermia as well, right? So we are a bit worried about acrocyanosis, that is peripheral cyanosis. But peripheral cyanosis can be due to hypothermia, due to low temperature in the environment, right? Therefore, don't get, just reassure the parents this is peripheral cyanosis which happens in the peripheries of the legs and peripheries of the upper limbs. But always check the tongue. If the tongue is also cyanosed, you have to be really worried because it's a sinister cause, because it might be a central cyanose. But if the tongue is pink and peripheries are cyanosed, you don't have to worry. So that's must be a local reason. Local reason may be hypothermia, or baby is exposed to cold, or baby is exposed to air conditioner. So therefore, you can reassure them, and but always examine the tongue, right? Right. So breast engorgement. So always breast can be engorged due to maternal hormonal activity. So always check whether it is reddened and inflamed. If it is reddened and inflamed, somebody might have squeezed it. So this normal breast engorgement is very, very normal. It's due to maternal hormonal changes. But with maternal hormonal changes, when maternal hormone levels goes down, it will settle on its own. But in our traditional, some people in our culture, some people believe that it should be squeezed out, which is very dangerous, which can infect the breast tissue, and which will collect pus in the breast tissue, and which will be very painful for the baby. Sometimes we may have to put an excision and drain the pus, right? So therefore, never allow them to squeeze. Just reassure them it will settle on their own. when the maternal hormone levels goes down, right? Milia, it's a multiple 1 to 2 millimeter yellow whitish cystic lesions, right? Affected almost 40% of the babies, right? Found most commonly over the cheeks, forehead, nose, and nasolabial folds due to blocked sebaceous glands, known as Epstein pearls when they occur in the oral cavity. Self-limited and are reabsorbed within, book says 3 months, but within 1 or 2 months it will be settled. You don't have to do anything, right? Miliaria, that's heat rash, small erythematous papules and pustules on the forehead, neck, upper trunk, usually after first week of life, resulting from occlusion of the and rupture of the sweat ducts in the skin. But that is also a self-limiting thing. Might be responding to avoidance of overheating, removal of excessive clothing, and cool beds will help. And applying topical creams will might worsen the scenario. Therefore, don't apply anything. Let it settle on its own. Right? Erythema toxicum, we call it Rata, Rata Gaya. Rata, we call it sometimes they give Rata Kalke, which is not anymore recommended. Very common rash occurs in almost 50%. Small white yellow papules and pustules. Sometimes it may turn into red. Usually develop 2 to 3 days after births. Wearing the palms and sole. Lesions seem to be migrate by disappearing within hours and then reappearing elsewhere. Resolve within 2 weeks. Don't apply anything. Don't recommend Rata Kalke because Rata Kalke contains a lot of products which are not recommended. It might damage the damage kidneys and it might damage liver. Therefore, uh, reassure the parents that it will settle on their own. Don't do anything, right? Transit neonatal pustular melanosis, small superficial white pustules on the non-erythematous base present at the time of delivery on the neck, back and extremities and palms or soles. New lesions do not usually appear after birth. That is very characteristic. The lesions are static. No more new lesions, right? Often resolving within 2 to 3 days. Don't do anything. I don't apply creams. It might, it might block further sweat glands and might worsen the condition. Therefore, don't apply anything. Just let it disappear on its own, right? Sucking blisters, flaccid bullae, 5 to 15 millimeters, produced by vigorous sucking of the during the fetal period, may evolve quickly to erosion, resolve in days, not actually week. Characteristic locations are radial, forearm, wrist, hand. No need of treatment, it will settle on its own, right? By applying some cream and applying powder won't help the healing process, right? Mongolian blue spots, mothers are really worried. Cosmetically, especially it happens in female babies, but make sure that it's just a temporary thing, which is due to some vascular malformations, actually venous malformation, but it will disappear by 6 to uh, during 6 months to 1 year time. It will disappear and it will not reappear again. Therefore, they are really they are really worried about the cosmetical effect of the Mongolian blues, but make sure that it will disappear in 6 to 12 months. It won't persist in the longer period, right? Strawberry hemangiomas, bright red, raised, well circumscribed lesions can be found all over the place. Grow rapidly during 6 months, continue to grow till 1 year. More common in head, neck, and trunk in premature babies and might regress after 1 year, but sometimes large strawberry hemangiomas can lead to bleeding. Therefore, and sometimes large ones, if you get a large one on the skin, you may have to do a ultrasound scan to see whether it has any continuation in the inside organs also. Therefore, depending on the uh, place where it appears, plan for further investigation. If it appears on the face, nearby the eye, nearby the nose, and nearby the mouth, always make a suspicion whether it has some continuation in the inside the skull. Therefore, and when it appears in the abdomen also, make sure by doing ultrasound abdomen, it doesn't appear on the inside the abdomen, right? So if it is growing larger, it might lead into bleeding, it might lead to real, it might lead to heart failure, and it might get infected. Therefore, wait for some time. If it doesn't resolve, you can apply steroid cream and you can start propranolol and get the plastic surgeon's advice. They can authorize it. They can do various sort of treatment modalities to remove that, right? So basically corticosteroids and propranolol treatment will help to remove that. Cephalohematomas, when you are struggling with the delivery, when the delivery baby gets stuck on the vaginal canal and you are pulling the baby out, you get a cephalohematoma. It's a collection between the tight skin of the cranium and the bone, right? So it's very well, the place is very well demarcated to the bone. Therefore, it can be a bit painful, right? So the problem is the bleeding into that cavity is very painful because it's a very tight compartment. And with time to come, the blood will degrade and it might end up in jaundice. It might be a focus for jaundice, right? Therefore, just give some pain relief. So mother's worries, it will persist and the head shape of the head will be the same. No, you have to reassure the mother, it will absorb on its own and we don't have to do anything else but keep an eye on jaundice, right? So if it is very painful and tight, it's always better to give some paracetamol, that is 15 milligram per kg, 3 times a day for 3 days, just to avoid the tenderness and pain, right? So it's maybe due to prolonged stage 2 labor. Instrumental delivery is one of the known causes of cephalhematoma. The mishappened head can cause some parental alarm, right? So they might think that it still persists. Periosteal swelling can also be present. Boundaries is limited by bony margin. Does not cross the midline. That's a characteristic feature, right? Then caput succeedium, that is also due to boggy diffuse edematous swelling or soft tissues of scalp over the presenting part. The swelling is present at birth and the size and severity is related to the duration of labor. So swelling is pitting on fluctuant and not limited by sutures. Unlike cephalhematoma, it disappears spontaneously over next few days, but that also can be very painful. Therefore, always, if it is painful, give some paracetamol, 15 milligram per kg, 3 times a day, right? So in case of female newborns, you get vaginal bleeding due to maternal hormonal imbalance. It's almost like menstruation, but in a small quantity, small volume, but it's really matter of a concern for parents. Parents might bring the child running to you saying that the bleeding has occurred. They want to do something to stop bleeding. Once again, you have to tell the pathophysiology this is something very similar to menstrual bleeding because of the maternal hormones. The bleeding occur and after maternal hormone levels go down, it will automatically stop. But keep an eye on that. Don't neglect the bleeding. But if it is very severe, once again, you may have to review with the protein profile, right? So same in the case of mucoid vaginal secretions. Most female babies have thin grayish white mucoid vaginal secretion. This should not be mistaken for purulent discharge. So that is also mucoid vaginal secretion, also due to maternal hormone changes, but it will settle on its own. We don't have to do anything, right? Urate crystals. So when you get a diaper, you may get a red color marks on the diaper. So parents are alarmed. They might think there's bleeding has occurred in the urinary tract, and they might come to you once again. Make explain them that these are the urate crystals. So that might find intermittently in the diapers. In first week, it will disappear on its own, but it can be a mark of inadequate hydration also. If you increase the hydration, if you properly correct the hydration, it will disappear on its own, right? Cutis marmorata is not that common in Sri Lanka, but it's a bluish mottling of skin in response to chilling, stress, or overstimulation. Resolves quickly within warming. It's very common in cold countries. Onset during first 2 to 4 weeks of life due to immaturity of the autonomic nervous system, right? It persists if first after the infant is warmed implies an obstruction to blood flow such as hyperviscosity like high PCV or vasculitis, right? So persistence beyond neonatal period is a possible marker for trisomy 18 and Down syndrome. Therefore, if it disappeared by 2 to 4 weeks, you don't have to worry. But if it doesn't disappear, you have to check the PCV, packed cell volume, and think about certain syndromes which is a presenting features cutis mammarota, right? Like trisomy and trisomy 18, trisomy 21 and 18, right? So subconjunctival hemorrhage is very common after normal vaginal delivery when the baby head gets stuck in the vagina. Small vessels in the eyes get ruptured and bleeding can occur bilaterally in the conjunctiva. But by seeing this, parents might get agitated and alerted. So they might think that it's a serious condition, but we have to explain them. This will absorb on his own and you don't have to do anything, but keep an eye on this because if further bleeding occurs, it might be a very rare presentation of bleeding manifestation, right? Nasolacrimal duct obstruction. So most of the time, parents will come to you. Excessive tearing, right? Excessive tearing. Sometimes pus also may be there. Then you have to examine the eye. If the soft tissue surrounding the eye is also swollen and edematous, you have to think about the eye infection, but most of the time it's not like that, just a lacrimation only. So that is due to approximately 6% of newborn, one or both of the lacrimal duct is blocked, preventing drainage of tears. So affected children appear to have excessive tearing. 90% blocked, ducts open spontaneously by 6 months of age. Otherwise, you have to massage it 3 times a day. That will open the duct automatically, right? Warm compress or massage from outer or inner canal force milk the duct, resulting in resolution of majority of cases. If secondarily infected, may need topical antibiotics. Just see whether the surrounding tissue is reddened and inflamed and infected. If it is so, just give a eye drop, right? Weight loss, which is a really hurting word for the mother. So, the weight loss is any baby loses about 10% of weight during first 14 days. So that is physiological, right? But you have to tell the mother this is very normal. Everybody, every newborn loses 10% of weight during the first 14 hours, right? You tell that. If it is not so, if you're just going to say that baby has lost 7%, 8%, or 9%, it really hurts. The mother will think only her child has lost the weight, right? Which is once again is a negative impact on the breastfeeding. When you hurt the mother, when you disturb the mother, it also hurts the breastfeeding. It also has a negative effect on breastfeeding. Therefore, you have to tell the specifically mother weight loss is very physiological. In every baby, it happens. It's not only for your baby, right? 10% weight loss is very normal within first 14 days, and then he will recover on his own. If it is not so, you have to take some remedy, right? Then after 14 days, he will re-achieve the birth weight, and there onwards, he will achieve 20 to 40 grams per day, right? So the thing that I want to highlight is don't stress on weight loss because it hurts the mother. So just say it's a physiological thing. Everybody, every newborn loses about 10% within 14 days, and he or she will recover on his own, right? If it is not so, you have to take a remedial action. Otherwise, you don't have to do anything. They will recover on their own. Right. So dehydration fever. Mothers have a lot of complaints about dehydration fevers. So babies usually healthy, they are very active, they are feeding vigorously, right? So this occurs 3 or 4 days of life due to uh, poor feeding, right? So feeding is very vigorous. So maybe due to inadequate breast milk, maybe due to technique is not correct. So always differentiate from sepsis. In sepsis, babies behave in a different way, but in this one, babies are completely behaving in normal way, but they are bit dehydrated and urine output is reduced. and they are vigorously looking for feeds, right? So baby should be dressed with loose cotton clothes, and always look whether baby is active and alert. So that means baby is not septic, right? So problem is respiratory system. So see if the rate is if the rate up to 60 is normal for newborns, right? And see whether the grunting is present. Grunting is very significant finding of respiratory distress, and lower chest syndrome. Those are also very significant, and respiratory distress can cause central cyanosis, right? So in premature babies, if the maturity is less than 37, you may find hyaline membrane disease, or you call it now surfactant deficient lung disease. Sometimes by mistake, pediatric households may have discharged a premature baby. So when they go home, the baby might be brought to you with respiratory distress. So you just check the maturity. If the maturity is less than 37, if the chest indrawing are there and respiratory rate is more than 60, and baby's skin is also premature, not mature enough, that indicates the baby is having surfactant deficient lung disease. And there are some risk factors for surfactant deficient lung disease. If the mother is diabetic, and if the mother is hypothyroidism, if the mother is having gestational diabetes mellitus, all those things are. And if even the baby is term, the baby has had a delivery with hypoxia, I mean bit of a disturbed delivery with birth asphyxia, that might precipitate surfactant uh, deficient lung disease. So that you may have to, there's no solution that you can give. You may have to admit the patient back to the ward even after the patient has been discharged from the ward. So you have to readmit the patient to ward for treatment. Right. 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 So characteristics, they are very tachypneic, nasal flaring is there, subcostal and intercostal retractions are, cyanosis is there, and expiratory grunting is very common and very significant. Right. So when you take a X-ray, you can see lung volume is decreased. Therefore, you get a bell-shaped thorax. Air bronchogram can be seen, and very hazy ground glass-like appearance is found in the chest X-ray, right? Opaque lung, right? So therefore, whatever it is, you have to admit the child back to the ward for treatment. So sometimes the mothers had prolonged rupture of membrane, and mothers had untreated urinary tract infections, right? Uh, Even after baby is discharged from ward, premature or mature babies, when they go home in 2 to 3 days time, they might develop respiratory distress with severe chest indrawing and high respiratory rate, right? So risk factors is premature rupture of membrane, prolonged labor, premature rupture of membrane for more than 18 hours, prolonged labor, and unclean vaginal examinations, foul smelling lico, and maternal fever with, as I told you, untreated urinary tract infections. Babies can present with congenital pneumonia. So in the congenital pneumonia also, you see X-rays hazy, and you get a white color patches throughout the X-ray, which marks the uh, pneumonic patches all over the place. So positive organisms are group B Streptococcus, gram-negative organisms, E. coli, Klebsiella, and Pseudomonas. So as I told you, clinical manifestation will be respiratory distress, recurrent apneic attacks, right? They can often asphyxiate. They are often asphyxiated and sick at birth, prolonged capillary filling time, and hypothermia. And so you have to readmit the patient back to the ward. And sometimes in term babies, meconium aspiration is common, right? So if the delivery, if you found meconium on the delivery, so you have to suspect meconium aspiration. So rather than discharging the baby, you have to find out whether the meconium is really aspirated, whether the baby is in distress. whether the X-ray has the typical appearance of meconium, and then we'll treat them. So 10 to 15% of births meconium stained amniotic fluid, 5% will get meconium aspiration pneumonia. So out of that thing, 30% requires mechanical ventilation. Now our setups are developed, therefore we can, without, I mean, we can, most of the time we can survive meconium aspiration babies, right? Right. So risk factors for meconium aspiration: placental dysfunction, placental insufficiency, fetal hypoxia, antepartum hemorrhages, post-maturity baby, and sometimes lysis and sometimes abnormal presentation. Anything which can cause distress on the baby can present with meconium aspiration. So if you find any evidence of respiratory distress in term baby, and when the baby is brought to you, you might suspect meconium aspiration and re-admit the baby for treatment, right? So you get cotton wool shaped appearance throughout the X-ray, which indicates that meconium is found in the chest X-ray, right? So periodic breathing, patients are really worried about this. Baby take normal breaths. Intermittently, he or she takes bit of a fast breaths, one or two, and then breathes very rapidly for few seconds, then pauses and then resumes normal rhythmic breathing pattern, right? Brief pauses should be less than 10 seconds. Then normal breathing pattern once again restarted. Not associated in bradycardia or most common in preterm. Not associated with bradycardia or any other vital signs. Most common preterm babies, so they will resume their normal breathing pattern, so which is called periodic breathing pattern. Very common presentation in private practice. Parents are really worried and alarmed, so they bring the baby to you, but you have to take the good history and detect whether it's a periodic breathing or not. If it's a periodic breathing, you have to tell them this happens when the respiratory center is not mature. So with time it will settle, and you have to send them back home after giving reassurance, right? So transient tachypnea of the newborn, that happens most of the time when the babies are term babies are delivered through the vaginal canal. They are being squeezed in the vagina, so the fluid in the lungs is reabsorbed very fast and naturally when the babies are squeezed. But in cesarean section, they are being artificially taken from the abdomen, so babies are not being squeezed. So lungs are full of fluid and lungs are wet. So therefore, the wet lungs will have bit of a alveolar collapse. Therefore, they give alveoli is bit the air exchange alveolus bit number is bit limited. Therefore, limited number of alveoli bit exhausted in exchanging gas. Therefore, they end up in tachypnea, right? So benign self-limited respiratory disorder characterized by mild respiratory distress immediately after birth, usually full term and well looking, common in those delivered by cesarean section, right? And not that common in normal vaginal delivery, right? So, and results from slow absorption of lung fluid, peaks about 36 hours of life, resolution within 24 to 72 hours. But it's sometimes may be difficult to identify from group B streptococcus. Therefore, always take X-ray and do other tests to differentiate whether it's a TTN or group B streptococcus or congenital pneumonia, right? Problems in cardiovascular system, which is also very important topic. So always look for the history and examination. Always, if you're suspecting a cardiovascular system, it can problem in cardiovascular system. It can be a cyanotic congenital heart disease or acyanotic one, right? If it is most probably an acyanotic one, you find a very good murmur, right? If you get a good murmur, always see the preductal and postductal saturations are normal. So murmur, check for the pre and postductal saturations, right? What is preductal? Preductal is right hand. It's called preductal. That is oxygen before going to the brain is called preductal. So you get the preductal saturation in the right hand, right? So see the preductal saturation. It should be above 95. And check the postductal saturation. That is left lower limb. So if you find a murmur, Okay, if you find a murmur, always check for preductal and postductal saturation. That is, preductal is left, sorry, right arm, and postductal is left leg. So if that is above 95, you don't have to worry. And if preductal saturation and postductal saturations are less than 95 with a murmur, so you have to be cautious. That means you need an echocardiogram to assess the murmur, right? And if the preductal saturations, if the pre and postductal are both low, you have to be cautious about the uh, heart disease. So you have to end up in get a echocardiogram done. If the preductal saturation is normal, 95, 96, and postductal, that is left leg, is less. So we'll say preductal is 95, postductal is 85 or something like that. That means the baby is having persistent pulmonary hypertension. You get what I said? That is, preductal is right arm. If the right arm is somewhere around 95 or 96, and the postductal is left leg, somewhere around 85 or 86, which is about 5 lesser than the preductal, that means baby is having some cardiac anomaly, which is called the persistent pulmonary hypertension, right? If preductal and postductal are both low, it is a clue for cyanotic heart disease, right? Therefore, always if you find a murmur, always check the preductal, postductal saturations. If you find a central cyanosis, that is tongue is cyanose, always you have to do a echo immediately to find that is a cyanotic heart and the type of the lesion, right? So simple. So preductal, postductal, and saturation. Then sometimes child might present to you with murmur plus respiratory distress, poor feeding, hepatomegaly, and tachycardia. That means baby has a cardiac lesion which has gone into heart failure. So at your level, so if you have identified there's a heart lesion, whatever the lesion is not a problem, but you have identified there's a lesion and you have identified that baby has gone to heart failure, that is enough. You have to refer to higher center or refer to ward and admit the patient for further management, right? So there are various heart lesions. PDA is one of the common that we can find. Doctors even patient patent term and preterm, most common in preterm. There's a left to right shunt which will make the lungs wet and baby will find a bit of a distress in respiratory distress. So small PDAs are asymptomatic and large PDAs left ventricular hypertrophy and biventricular hypertrophy. So most of the time we try to close the PDA by giving paracetamol and brufen. Most of the time, the treatment will be successful. If we don't get it closed by paracetamol and brufen, ibuprofen, we will refer to cardiac centers like LRH, right? Or then they will decide the mode of treatment, maybe ligation, maybe surgical closure, right? Hepatology of fellows, those things are also found, but the prominent feature will be cyanosis. So in the case of cyanosis, we are not going to deal with cyanotic heart disease. We just do the echo and refer to experienced cardiac centers like LRH for further management, right? So in the central nervous system, when we are talking about central nervous system, birth asphyxia. Now the birth asphyxia is not that common because we are monitoring the fetal and maternal well-being very closely. Therefore, when the baby is going into hypoxia and when the baby is going to stress, we do intervention and get the babies out as much as possible. But still, there are some cases of perinatal asphyxia is found in even in the tertiary setup, right? So when the baby perinatal asphyxia is an insult of the fetus of the newborn due to lack of oxygen and lack of perfusion to various in organ levels, including the brain, right? We have to establish efficient breathing in 1 minute of age with hypoxia, and will end up in brain damage and multiple organ damage. So, so APGAI is the most practical measuring tool for asphyxia, but in case of preterm babies and babies with birth trauma and congenital neurological abnormalities, APGAI very difficult to measure, right? But anyway, APGAI is the most uh, practical tool that we use to measure the amount of asphyxia, right? So asphyxia can occur in antepartum level, intrapartum, and postnatal period. Whatever it is, it's our duty to prevent that, right? So in antepartum conditions, abnormal maternal oxygenation, severe anemia, cardiopulmonary disease, and those things will contribute. Inadequate placental perfusion, severe hypertension, and congenital infection and abnormalities play a role. Then interpartum events, interruption of the umbilical circulation, do not cord prolapse, those are also contribute for interpartum events. Inadequate placental perfusion, rupture of placenta, uterine rupture, and abnormal uterine contraction also plays a role. Then, right. So whatever it is, when you place it birth asphyxia, if the birth asphyxia has affected the brain, you call it hypoxic ischemic encephalopathy. The most serious complication of perinatal asphyxia, that's a neurological sequelae after birth asphyxia. So hypoxia impairs cerebral oxidative mechanism and leads to myocardial depression. This leads to fail in cerebral blood flow. And then ischemia of the brain tissue occur, persistence of hypoxia increase anaerobic glycolysis, which leads to lactic acid, which will worsen the situation, which have a negative impact on heart as well as kidney, as well as gut, as well as every tissue in the body. Worsening of lactic acidosis, if not corrected on time, causes loss of cerebral vascular autoregulation, which will worsen the matter and which will cause ischemia worse, right? So most of the time, prolonged partial episode of asphyxia is because of abruption placenta. That is very common in our setup. And usually it causes diffuse cerebral necrosis. Clinical, this may be present in form of seizure and paralysis. So anyway, whatever it is, according to clinical picture, we grade them. We call it Sarnet staging of hypoxia. Grade 1, which is mild. So level of consciousness is irritable or hyper alert, muscle tone normal or hypertonia, tender reflexes increased, seizures is not there, and complex reflexes normal. Then prognosis will be good, almost similar to a normal baby. Then in grade 2, level of consciousness will be lethargic, muscle tone will be hypotonic, tender reflexes are increased, seizures will be there. So in grade 1, there won't be seizures, but in grade 2, there are seizures. Then complex reflexes are weak and prognosis will be, not normal because sequel is there. Grade 3 severe, very bad prognosis, right? Right. In neonatal seizures, that indicates that cerebral damage has occurred, right? So immature brain is more likely to develop seizures, not similar to adults. So most of the time, the myelination has not been completed, therefore damage is a bit severe, right? So in causes of neonatal seizures, in 1 to 4 days, hypoxic ischemic encephalopathy, in intraventricular hemorrhage, drug toxicity like certain drugs taken by mother, and acute metabolic disorders are the causes. Then 4 to 15 days infection, CNS infection like meningitis, metabolic disorders like hypoglycemia, hypocalcemia will be there. And benign neonatal conversion also plays a role. And sometimes kernicterus also, even it is not that common now, it also was those days, right? So in 2 to 8 weeks, once again, infection, head injury, inherited disorders of cortical development are the causes, right? So whatever it is, neonatal conversions may not be presenting to you typically. It may present to you in eye rolling movements, tongue biting movements, and so many abnormal ways, right? So eye rolling movements, tongue biting movements, cyclical movements are also way of presenting of neonatal conversions, right? So facial nerve palsy, that is when you see a face, when the child cries, the face diverted to normal normal facial nerve side. That in this case, its left side is normal, right? So face is mouth is diverted to left side. So right side eyes cannot be closed. Right side mouth is diverted to left side. That means right side facial nerve damage has occurred, right? So that's most probably in the birth trauma, right? Lower motor type of lesion. It might uh, uh, where severity may be variable. Difficulty sucking, drooling of feet on affected side. Most resolve spontaneously within weeks, but sometimes if it is not uh, recovering within expected time, we may have to use prednisone. We may have to get the neurologist's opinion. We may have to get nerve stimulation tests done, right? Nerve stimulation has to be done to recover fast, right? So really, parents are really worried and concerned about the appearance and the nerve palsy. But once again, it needs some time to recover, and you have to counsel the parents and stage. You have to explain them the treatment is not just by 1 day or 2 days you can't recover, but it will take some time. You have to explain them, right? Okay. Then spinal defects, so many varieties are there. So even you find in if you find some kind of abnormality in the spine, whether it is spina bifida or spina bifida occulta or tuft of hair or lipoma, it's always better to do a scan of the spine and differentiate the type of the lesions. Can be spina bifida, right? So even you find any midline defect, always do a spine of the scan of the spine and get it sorted out, whether it's a spina bifida or spina bifida occulta, whatever it is, and refer to neurosurgery. There are various types, right? So, and so whatever it is, you are not going to handle it. You just do a scan and make sure that some spinal cord defect is there and refer to neurosurgeon. Right then, encephalocele, that also you know. Cranial meningocele or myelomeningocele most often occur in the occipital area. Once again, you are not going to manage. You just refer to neurosurgeon. But whatever it is, you have to tell the parents that it's a complex process. You need to you need some time to treat the baby, and it's not a very rapid recovering thing. You need to be patient and oblige with the treatment line and get the treatment done, and will be other multidisciplinary actions will also be followed, like physiotherapy, and the other system has to be screened, and development follow-up also has to be accompanied with the treatment, right? So then Erb's palsy, injury to the fifth and sixth cervical nerve, that's also brachial, Erb's palsy, brachial plexus injury. Most of the time occurs in normal delivery of the large babies, right? Injury to fifth and sixth cervical nerves associated with difficult delivery. Frequently babies weighing 3.5, 4 kilograms, like large babies. No spontaneous arm movement on one side. Forearm is extended and pronated. These improve in 90% of cases. But if there's no recovery after 3 months, always get the plastic surgeon's opinion and need to be explored surgically. But in your setup, if the when the baby is born, when you have detected the palsy, it's always better to get a higher baby should be referred to higher center and get their opinion about the management. You know, it's a palsy, so sometimes they start very light physiotherapy, but it's also under I'm under rheumatologist's opinion, or if the rheumatologist can't set it within 3 months, always better to get a plastic surgery. So therefore, better to refer to a higher center for their opinion. Otherwise, you will won't be able to recover it fully, right? Right. Jitteriness, very common finding in neonates. Tremor that is stimulus sensitive and can be stopped by passively flexing the affected limb. So how does it differ from conversion? When you, in a case of conversion, you can't stop it by passively holding it. Conversion will occur, but in jitteriness, you can stop it, right? Jitteriness is not accompanied by autonomic changes. There won't be any sweating, there won't be any eye rolling movements, there won't be any change in the heart rate, just jitteriness only, right? Right, then sometimes can be associated with hypoglycemia, hypercalcemia, and IVH, intraventricular hemorrhage. Therefore, if you find a jittery baby, always check their glucose levels, calciumic levels, and do a scan of the brain just to see whether the baby is having IVS. Sometimes it can be, jitteriness can be a feature of meningitis also. Therefore, the baby is generally not well. Always try to do a septic screen to exclude meningitis, right? There are problems in abdomen. Vomiting. Vomiting can be due to gastric irritation by amniotic fluid, maternal blood. So many. Therefore, always better to give a, if the child vomits frequently just after delivery, always better to give a gastric wash and see, right? If the vomiting is non-bilious, you don't have to worry that much. Just give a gastric wash and see. If it is persisting, you may have to further investigate. Gastric irritation by swallowed maternal blood is maybe due to cracked bleeding nipple, antepartum hemorrhage. Baby may pass Malina stools rather than meconium. Therefore, you know that's a irritation by swallowed maternal blood. Then gastroesophageal reflux. That is due to overfeeding and improper feeding. So when the gas gets accumulated in the abdomen, it's very uneasy for the baby. They usually vomit with a lot of gastric contents, which will make the baby uneasy, right? So effortless after feed end on lying flat, right? So always see whether child is vomiting is not that forceful. If it is forceful, always investigate, do an ultrasound scan and see if there are any obstructions, right? If it settle and the feeding technique is correct, right? Or sometimes might settle it domperidone, right? So you have, just keep it in mind whether you have excluded any GI obstruction and CNS infection. So examine and see whether the baby is otherwise normal, right? Right. Bowel pattern and constipation, frequency of stooling in breastfeed can vary from where every feeds babies might pass stools, right? Sometimes watery stools with a bit of a yellowish nodules like stool. So those things are called breast milk stool. That is normal. Sometimes mothers may misdiagnose it for diarrhea. Just make them reassure that it's not diarrhea, it's normal stools. But in breast milk stools may be very frequent with bit of acidic watery secretions. In formula feeds, it might be occurring once in 3 days. Therefore, you get very loose paripueta-like stools in breastfeed. That's normal. Sometimes mother might mistake it for diarrhea, right? So constipation is uncommon in newborn. Constipation occurs. You also first thing you have to do is check whether baby has undergone thyroid screening. If the baby's TSH level is normal, because hypothyroidism, constipation is one of the presenting way of hypothyroidism. And the other thing is you have to ask the mother whether the baby has passed meconium within first 24 hours. If it is not so, you are giving a clue for Hirschsprung disease and do the further investigations, get opinion from the surgical team, right? Failure to pass urine if the hydration is normal, there's no way that baby is not going to pass urine. Always check the bladder is full. If the bladder is full, you don't have to worry. Just give a small stimulation to middle aspect of the thigh and allow the baby to pass urine. If baby after birth, most babies widen the first, but all babies must pass urine by 48 hours of age. Babies with delayed passage of urine should be investigated for obstructive uropathy and renal agencies, but most of the time they pass, right? Normal babies void urine 6 to 12 times per day, right? Some babies cry before passing it. That's just to make pressure to open the sphincters. If they cry before passing urine, you don't have to worry. But if they cry while passing the urine, you have to look into that. Maybe child may be having urinary tract infection, right? So sometimes after passing urine, also they might cry because the nappies are wet, right? Okay. Then most of the time, parents will come to you saying that babies cry during passing urine. Always get the timing properly. If they cry before passing the urine, there's nothing much you can say. That is because of the tightness of the sphincters. With the time, they will overcome the tightness and they will settle. But while passing the urine, if they cry, just examine the genitalia. There might be some irritation in the genitalia, irritation factors. There might be excoriation in the genitalia, or it can be due to urinary tract infection, right? Therefore, ask the timing properly, right? Right. Then umbilical sepsis. So when umbilicus is infected, you get a wall ring, like that is a ring of infected tissue around the umbilicus, right? So that is very dangerous. Umbilical cord normally falls off in 7 to 10 days and wound heals about 15 days. Redness and swelling around the umbilicus, we call it wall ring. And sometimes there might be pus discharge. This is very dangerous. It might spread the infection to umbilicus and it might lead to portal vein thrombosis, right? Therefore, just identify it and clean the space and start antibiotic as soon as possible, right? If redness is surrounded area is less than 1 centimeter or there are signs of sepsis, then in addition to local therapy, systemic antibiotics should be started as manageable septicemia, right? Complication is sepsis, you might end up with cellulitis, and portal vein thrombosis is the most dangerous complication. Umbilical granulomas, I mean, you just have to cauterize, then it will settle on their own, right? Uh, how is our timing? Huh? How am I allowed to go? How many minutes? Huh? Right, okay. Right. Necrotizing enterocolitis is characterized by necrosis of the intestinal wall, is serious life-threatening condition that is being diagnosed with increasing frequency in frequent premature baby infants. Especially, it's a condition where premature babies get their bowels distended and passing blood-stained stools and persistent vomiting. When sometimes we tend to discharge premature babies home, right? Because we can't be keeping them until they reach their maturity. But when the weight gain is good, when the baby's development is good, satisfied, we can discharge them, right? So when they go home, sometimes they might come to you with distended abdomen. Mother might say baby's apathy, baby's activities are less, and baby sometimes ceases his or her breathing with a bit of abdominal distension. And you might see some stools, blood-stained stool in the blood-stained stools. So that can be a clue to neck. Neck is due to characterized by necrosis of the intestinal wall. It's a serious life-threatening condition. Might end up in perforation. Therefore, you have to identify it. It's basically premature babies are more liable for neck, but sometimes term babies who has had hypoxia and some problems like meconium also liable for neck. Therefore, identify that features will be apathy, apneic attacks, abdominal distension, right? And passing of blood-stained stools, right? So, contributory factors include perinatal asphyxia, low ABGAS score, surfactant deficient lung disease, sepsis, early starting of the enteral feeds also might contribute for neck, right? So when the gut is not mature, but we are trying to feed the fellow, so that might end up in necrosis, right? And congenital cardiac disease like PDA, right? Because the PDA will shunt the blood from left side to right side, so which will make the gut necrose, which will make the gut hypoxic. Therefore, it is more liable to get necrotizing enterocolitis, right? Relative ischemia of the intestinal tract, that is due to hypotension. And use of umbilical catheters might also cause damage to the blood flow of the intestine, which can expose to hypoxic part in the gut, which will end up in necrotizing enterocolitis, right? So, as I told you, abdominal distension, decreased bowel sounds, poor feeding, increased gastric residuals, blood-streak bile vomiting, bloody or mucoid stools are the features of neck, right? Right. So metabolic problems, we'll go through the metabolic problems as soon as possible. Jaundice is not that. As you see the jaundice, you have to be a bit vigilant and you have to assess it. So common problem is, and most of the time is benign, but I will show you a chart. Uh, so what you have to do is assess the severity of the jaundice, right? So pathological versus physiological, right? So physiological jaundice appears in 2 to 3 days, right? Pathological appears in first 24 hours. So rising of the bilirubin is very fast in pathological. That is more than 5 milligrams per deciliter per day. In physiological, that's less than 5 milligrams per deciliter per day, right? Right. So uh, if the bilirubin level is very rapidly spreading, right? If the baby is becoming very jaundice, better to do basic screening tests like serum bilirubin level and blood group, and send the baby to hospital for further evaluation. If the face is jaundice, that means uh, bilirubin level is 5 to 7. If the chest is there, so bilirubin level is 10, right? If the lower abdomen is and thigh is there, there is 12. So if the sole and palms, that is more than 15. That's at the level of chest and abdomen. I think you may have to admit the baby and start for the therapy, right? So this is the graph that we use. So areas are shown 1, 2, 3, 1, 2, 3, 4. Right? If you to get into the level 2 and coming to the level 3, it's better to admit and do the necessary. Right? So if the bilirubin level is rising and if the bilirubin crosses the blood-brain barrier and get deposited in the basal ganglia and hippocampal, and it will be disastrous. So baby lose the tone, then there will be no tone control, so that will end up in kernicterus, bilirubin encephalopathy will end up in cerebral palsy, right? Therefore, don't allow the bilirubin to rise. So if the bilirubin is rising rapidly, admit the baby, correct the hydration, do a proper hydration, and start phototherapy as soon as possible, right? If the baby is very rising, and chart the bilirubin and see if the baby needs double or single or triple phototherapy, start it immediately. If the baby needs exchange transfusion, do it as soon as possible. Don't wait for the report. If you feel that baby's bilirubin is rising rapidly, just start exchange transmission as soon as possible, right? Right. So hypoglycemia, most common metabolic disorder in terms, if the blood sugar is less than 45 milligrams per deciliter, you call it hypoglycemia. Or if it is less than 2.2 millimoles per deciliter, you call it hypoglycemia, right? So why are we worried about hypoglycemia? And that is neuroglycopenia. Neuroglycopenia, it causes neurological damage, which is irreversible. So if you found baby is hypoglycemic, just treat the fellow even without symptoms, right? So if the babies are low birth weight, that is below 2.5 kilograms, and if the babies are preterm, less than 35 weeks, if the Uh, if the baby's mother is suffering from gestation diabetes mellitus, right? If the hemolytic disease is there, and so check the RBS, random blood sugar, 2 hourly pre-feed, right? And babies on who was exposed to sepsis and birth asphyxia, shock, right? And mother receiving labetalol and nifedipine, right? So check the pre-feed RBS 2 hourly, and if it is low, less than 42 milligrams per deciliter, you have to treat. If the babies are symptomatic, you have to get the baby admitted and treat with 10% dextrose. Once the baby is stable, you have to replace 25% of the total volume of 10% dextrose by oral feed and stabilize the blood sugar, and gradually you have to withdraw the IV and turn into oral. If the babies are asymptomatic, you can always treat with breast milk. Or if the breast milk is not adequate, in that case, you can use, even for the term babies, you can use premature formula, because in premature formulas, sugar content is a bit higher than the normal formula. So usually in premature formulas, they get 100 ml contains about 82 kilocalories. So this, while giving the breast milk, you can top up on premature formulas if the baby is asymptomatic. If the baby is symptomatic, there's no excuse. You have to admit and treat the baby with 10% dextrose. If the baby is not recovering with 10% dextrose, you can have to increase the percentage into 12.5. Even if it's not responding for 12.5, you have to put a umbilical line or whatever central line and go up to 15% of dextrose. Then even the baby is not recovering for 15% of dextrose, you have to find out the cause. Most of the time, its cause is hyperinsulinism. So you have to start with anti-insulin drugs, right? So the message is, don't let the baby be hypoglycemic. It will end up in neuroglycopenia, which is a irreversible damage, which will have a sequelae, and child might be having permanent neurological sequelae later in life, right? So signs and symptoms of hypoglycemia: jitteriness, tachypnea, cyanosis, apnea, seizures, cardiac arrest, irritability, hypotonia, lethargy, high pitched cry, poor sucking and sweating, right? So prevention of hypoglycemia is always preventable. So always start feeds as soon as possible. Don't wait for 1 hour, 30 minutes. If you have a chance to start the feeds within 10 or 15 minutes, just start it within 10 or 15 minutes soon after delivery, right? And hypothermia. Hypothermia will start a sequelae of events leading to hypoglycemia. Therefore, prevent hypothermia as soon as possible, right? Congenital hypothyroidism, those are not common now, but it was common those days. Therefore, we have started neonatal screening for hypothyroidism, which is a THS yield pick test. Now I think we don't find hypothyroidism that much, right? So it's also correctable metabolic disorder, which have a direct impact on the brain development. So do a screening test as soon as possible. If you found it hypothyroid, start treatment as soon as possible. Don't delay, right? Right. Then line. So I think time factor is limited, even though we have a lot of things to discuss. So I will share the slides with you. You can get the slides. I think too much talking will not keep your attention now. So therefore, by this point, I would like to stop my lecture, and I would like to thank Dr. Dinesh and Dr. Manasi and the team of Sri and the GMOA, which gives you this chance for the knowledge and the CPD program in which I am the vice president for the last 4 years. And I would like to thank the entire team of Sri and the nation's team for giving this opportunity to speak to you. And I would like to especially thank my senior house, Dr. Ruchira Disanayak, for making all these slides and preparing these lectures for me. And Thank you very much for listening to me despite busy schedules. I know you are fighting high with the high and fighting with busy schedule with the COVID these days. But despite these all these problems, you had spent some time to listen to me. I hope at least you got some time, knowledge update from my lecture. And thank you very much for listening. Thanks.
Thank you very much, sir. That was very informative presentation today. We are running out of time, but still we'll be able to clear a few queries. We have got two queries from the participants, sir. The first question is, how can a mother get her 3 weeks old baby back to breastfeeding when the baby had been given formula a little after birth due to poor lactating?
I'll answer from here.
Yes.
The question is, can we get back to breastfeeding after 3 weeks? Is it? Yeah, you can. That's why I told you. I mean, there are no fast ways of getting back to the normal track in breastfeeding. So best thing is to the baby to be seen by you and assess the baby's feeding pattern, right? Then now, since the baby has been breastfed for last 3 weeks, baby has been adopted two mechanisms. That is, bottle feeding operates under different uh, bottle feeding operates under different mechanisms. So we have to slowly stop formula feeds, what do you call it, bottle feeds, and start cup feeding, right? Cup feeding and breastfeeding. Then give a breastfeeding, and you can encourage mother to form more and more milk. So that's a slow release of metoclopramide. I mean, it's not good to tell the commercial name, but for your knowledge, I think only one preparation is available. That is called digestine. So 40 milligrams nocte. So that pill produce bit of a milk for mother, and then start breastfeeding in the proper technique. And if the baby is not satisfied from the breastfeeding, you can start cup feeds. I know from day one, when you stop bottle feeds, the volume of milk will not be enough. So in that case, you can give breastfeeds as well as formula milk from the cup, right? Totally remove the bottle from mother, baby. Then the solution will be breastfeeds. If the baby wants some more, give formula from cup feeds. Then start the metoclopramide slow releasing agent, and as I told you, increase sleeping time. Counsel the mother psychologically, and then she will relax the mother. Don't put heavy burden on the mother. Sometimes we squeeze her breast. We try to give a target for the mother. Express 30 ml in 2 hours, 60 ml in 3 hours. Don't stress the mother. Right now, baby is already in formula. I know that, right? Allow the baby to suck from the breast under correct technique. Then, if there's any deficient, give it from formula from the cup, and relax the mother and give the what I told you, the slow metoclopramide solution, and arrange her diet and sleeping pattern. Avoid unnecessary caffeine and those kind of food from mother, and that will, from my experience, you can get the mother back to track in 1 to 2 weeks time.
Thank you very much, sir, for that excellent information. And one more question, sir. Is it recommended to get vaccinated for COVID-19 while continuing breastfeeding?
Yes, it's a practical problem, but our advice was, if it is below 6 months, better not, because I know everybody knows nothing will happen to the baby, but there are no, I mean, it's a new disease process, right? Therefore, there's no proper documentation is found in the world. So best thing, if the baby is less than 6 months, we can explain the parents the pros and cons about the vaccination. So if you don't get the vaccination, what will happen? Mother might get severe variety of COVID, right? Therefore, uh, what you call discuss the advantages and disadvantages and let them decide. My personal opinion is it's always better to give vaccination at any stage. But nobody is committed. Nobody is going to commit. Therefore, we openly say before 6 months, think twice, but after 6 months, definitely you can give. Before 6 months also you just discuss the options with the mother, saying that these are the, I mean, there are no known complications of vaccination in the feeding mother, but nothing is documented yet because it's a newly emerged disease, right? Still research has been done, but if somebody goes to courts, the rare side effects, what will happen, right? Those are the problems. So the fellow might argue in the courts, you have recommended vaccine for my mother, my wife, but he has got this much this side of effect, and this has affected my baby, right? So there's a very rare incident. Therefore, you just discuss with them. You don't tell them directly, go and vaccinate. Don't tell them. Tell them these are the benefits of the vaccination. Therefore, you decide these are the benefits. These are the dangers of not getting vaccine. Therefore, if you don't get the vaccine, the mother might get severe COVID variety, which might end up in ventilation. Most of the time, ventilated mothers won't survive. So therefore, you give them an open option to decide. So my personal advice is, if you are a good friend of mine, if you are a very close person of mine, my advice is go and get the vaccination and continue breastfeeding, right? So because if you are a good friend of mine, I know that if something goes wrong very rarely, also you won't sue me. Therefore, I will recommend you to go and get vaccine. But if you are not a known person to me, I will explain you these are the benefits of the vaccine. So you decide what to do. Okay.
Thank you, sir. We got few two queries, sir. What is the drug of choice for umbilical sepsis?
Flucloxamine.
And one more query. Could you please elaborate the correct technique or ways of burping after breastfeeding?
Yeah, best thing is to place the baby in prone position, and tap the fellow from back, so that the fellow automatically.
Thank you very much, sir. So here we are concluding our sessions today, and I would like to thank Dr. Sanjeeva Thenakon for his excellent presentation on behalf of GMOA and Society for Health Research and Innovation. Also, we would like to present a token of appreciation to Dr. Sanjeeva Thenakon. Thank you very much, sir, for joining us today. Here we are signing off. Thank you all for your participation. Have a good day. Stay safe. Thank you.